name's Jacob. I'm a final year medical student at Lancaster Medical School, and welcome to part one of this respirology series, where today we're going to be talking about adult asthma, particularly the pathophysiology and clinical features. So, with all that being said, let's get straight into the video. So before we get into the pathophysiology and clinical features of asthma, we just need to recap some respiratory physiology. Okay, so in the center here, we have a diagram of the lungs. And when we talk about gas exchange, essentially, we have two different zones comprised of different anatomical components. Okay, so we have a conducting zone. Conducting zone is also known as dead space, and that's where we don't have any gas exchange occurring. Okay, so this consists of the nose, the pharynx, and the larynx, the trachea, the left and right main bronchi, the bronchioles, so the branches of the bronchus of the bronchi, and then we also have the terminal bronchioles as well. Okay, so we also have the respiratory zone. Okay, and this is where we have gas exchange occurring. Okay, so we have exchange of CO2 and oxygen. All right, and the respiratory zone consists of respiratory bronchioles. So they're very, very fine, very small bronchioles, and they're just proximal to the alveolar sacs. Okay. And the reason why I'm saying this is because in asthma, it's mainly the conducting zone which is affected. Okay. Okay. So we have a diagram here. This is a cross section of a bronchiole within the conducting zone of the respiratory tract. Okay. So let's talk about some of the features of this diagram. So we have some blood vessels within a layer called the lamina propria, essentially like a loose, like a connective tissue layer. We have our ciliated epithelium. Remember, our cilia are these fine hair cells, and they help to clear particles from the respiratory tract. We have a thin mucus layer. The mucus is produced by specialized cells called goblet cells. Okay, we also have a fibrocartilaginous layer, and this is the outermost layer. And the amount and distribution of cartilage, specifically hyaline cartilage, varies as you go down the respiratory tract to the deeper parts. But that's more of an anatomy focused view of the topic. Something maybe is worth having a look at. We also have the lamina propria, which I've mentioned, which contains the blood vessels. And we have a smooth muscle layer too. So we've got this smooth muscle there, okay? And that's important when we think about stimulation of either contraction of the smooth muscle leading to bronchoconstriction or relaxation of the smooth muscle resulting in bronchodilation. And there's various factors which can affect this. Okay, and we also have the lumen of the bronchiole. And we can see from this diagram here, it's nice, it's a big, large lumen. Okay, and that's exactly what we want. Okay, first of all, let's talk about some definitions when we're talking about asthma. So, in simple terms, asthma is airway hyperresponsiveness causing variable and reversible airflow obstruction. Okay, and two of the main features of asthma, we have bronchospasm, so spasm of the, in particular, the smooth muscle within the bronchus, and we also have excessive production of secretions. Okay. So that's going to obstruct the airways, but remember that it is reversible airflow obstruction. Triggers can be upper respiratory tract infections, allergens, in particular, for example, pollen, air pollution, so fine particles within the air, cigarette smoke, particular drugs, so beta blockers or aspirin, for example, cold air, exercise, even stress, and gastroesophageal reflux disease. All important triggers to be aware of. So we have atopic asthma, and I want you to remember this as being allergic asthma, okay? And this is typically going to present in childhood. So in terms of it presenting in childhood, I like to think about it in terms of the different sexes, okay? So in being of male sex is basically a risk factor for developing childhood asthma. But if you're female, it's more likely that girls will continue to have asthma into adulthood. Okay, and atopy or atopic, just think allergic, and we're going to touch on that lots of times during the video. We also have non-atopic, so this is non-allergic asthma, and this typically presents in adulthood. And one of the sub-classifications we can have is occupational asthma. So asthma which is triggered, or the trigger is a result of person's occupation. Okay, so the most common trigger of occupational asthma or cause of occupational asthma is isocyanates. Okay, so isocyanates are a chemical found in foams, paints, different coatings, and also fibers. Okay, and when I say asthma, you probably automatically think about asthma in children, but it's also very important to recognise asthma as a cause of high morbidity and mortality in the elderly too. So it can happen in any demographic, and it's very important to be aware of as a doctor. Okay, so now let's talk about some of the risk factors and also some of the protective factors when we talk about asthma. So in terms of protective factors, vaginal birth has been shown to be a protective factor. The reason as to why isn't fully understood, and the opposite being a cesarean section. Personally, it could have something to do with the microbiota or different bacteria in terms of which pathogens colonize different areas of the body. So, but it's not fully understood, to be honest. Okay. We also have increasing sibship. So essentially what that is, that's where um, children have lots of siblings. And again, that's not fully understood why that's a protective factor. And also when children or people when they're in a farming environment. And this brings us on to something called the hygiene hypothesis, which is what I'm going to talk about in a second after we've delved into some of the risk factors. So in terms of the risk factors, we have a personal history of atopy. So when I say atopy, it means allergies. So, for example, allergic rhinitis. So hay fever is another term for allergic rhinitis, and eczema. And eczema is also known as, the fancy name for that is atopic dermatitis. Family history of allergies or atopy. If you're in an urban environment, obesity, prematurity and low birth weight, antibiotic exposure, in particular broad spectrum antibiotics, particularly from a young age, smoking and maternal smoking, so remember that passive smoking, childhood viral infections. I'm going to talk about respiratory syncytial virus, which is the most common childhood infection. HLA mutations and epigenetics can also contribute to the development of asthma. Okay, so essentially what we mean by the hygiene hypothesis is that the child's environment is too clean in the postnatal period. So essentially this prevents the maturation of the immune system. Okay, and this is just a theory at the current time, and there's more research is needed. But it's thought that there's a lack of T helper 1 stimulation leads to overactivity of T helper 2 cells. And we're going to talk about the involvement of T helper 2 cells when we talk about pathophysiology, and that'll make more sense then. Okay, and because the T helper 2 cells are more kind of in a excited state, they're going to increase the production of inflammatory cytokines. Like I said, the theory's not fully understood. Okay, and I just mentioned earlier it could have something to do with the interaction of the immune system and RSV, which is respiratory syncytial virus. It's the most common pathogen encountered in childhood. And also LPS is lipopolysaccharide. This is a glycoprotein in the outer membrane of gram-negative bacteria, which also has a role in maturation of the immune system. Okay, but everything I've just said there is, it's still up for debate, but I hope that makes a little more sense of it. Okay. Yeah, so now let's talk about aspirin-induced asthma. Okay, and when we talk about this, we have something called Sampter's triad. So for exams especially, this is important that you're aware of this. So this consists of asthma, aspirin sensitivity, and nasal polyps. Okay, and now I'm going to basically outline um, why this happens, so why aspirin can induce asthma. Okay, so imagine here we have our membrane phospholipids. Okay, these phospholipids can be converted to arachidonic acid by an enzyme called phospholipase A2. Arachidonic acid can be converted to prostaglandins, at this stage, prostaglandin PGH2, and this is by COX enzymes. Okay, so cyclooxygenase enzymes. PGH2 can then be converted to lots of different prostaglandins. So we have like D2, E2, F2, prostacyclin, which is also known as PGI2, and these substances called thromboxane. So we have thromboxane A2, which is the most common, and thromboxanes are involved in hemostasis. And this is just, you don't need to know the specifics of the enzyme. So let's just say for this, it's different synthase enzymes because they're making these different substances. Okay, arachidonic acid can also be converted to intermediates. So this is a very long name which you don't actually need to know, but it can be converted to these intermediates, HBETEs. You can look up the name for yourself if you get a chance. And this is done by LOXs. So LOXs are lipooxygenase enzymes. So we have our HPETEs, it's a bit of a mouthful, which can then be converted to leukotrienes. Okay, and at this stage it's leukotriene A4. This is by other lipooxygenase enzymes. So we have leukotriene A4 being converted to lipotoxins. There's other lipooxygenase enzymes, or it can be A4 can be converted to different leukotrienes. So B4, D4, C4. Sorry, B4, C4, D4, E4, etc. Okay, this is by enzymes called hydrolases. So when we have aspirin, okay, as you might already know, aspirin is an irreversible inhibitor of COX-1. All right, okay, I know this says COX here. There's COX-1, COX-2, but in particular, it's an irreversible inhibitor of COX-1. Okay, so we're not going to have arachidonic acid being converted to prostaglandin H2. Okay, and for whatever reason, because this pathway is blocked, we have increased activity of the leukotriene synthesis pathway. Okay, so we're going to have more leukotrienes being formed. In particular, C4, D4, and E4, when they're being synthesized more, they cause bronchospasm. Okay, so that's essentially the mechanism. These leukotrienes, C4, D4, and E4, they cause contraction of the smooth muscle and hence bronchospasm. Okay, so I hope that makes sense, and hopefully this is a good schematic to help you, understand the pathophysiology. Okay, so let's talk about the pathophysiology of adult asthma in lots of detail. So first of all, we have the first exposure to triggers. This sensitizes helper T cells, in particular T helper 2 cells. Okay, plasma cells produce immunoglobulin E, IgE, which binds to mast cells. Okay, and then we've got these activated mast cells lining the airways. Okay, then we have a second exposure to the triggers. Remember our triggers like the allergens, exercise, even the cold. Okay, so remember our triggers. And we have an early response within 0 to 2 hours, and we also have a delayed response, typically within 3 to 4 hours. Let's talk about the early response first. So basically, the allergens are going to cross-link these IgE antibodies on mast cells. So we're going to have lots of mast cells clumping together, are all going to be joined by the immunoglobulin E, particularly at the FC region of the immunoglobulin. And mast cells are going to release two important chemicals, what I want you to remember. So we've got our histamines, okay, and our leukotrienes. Remember we touched on leukotrienes when we were talking about aspirin-induced asthma. So in particular, histamine is going to cause increased vascular permeability. We're going to have hyperplasia, so increasing the number of cells of the goblet cells, and we're also going to have bronchial smooth muscle contraction, okay? So if we have increased vascular permeability, this is going to lead to airway edema, so airway swelling. And we're also going to, and the goblet cell hyperplasia, we've got increased mucus production. So we're physically blocking the airways. Like I said, so we're going to have that airway obstruction. Okay, and that's going to result in asthma. So let's talk about the delayed response. So 3 to 4 hours after the exposure, second exposure to the triggers. So we have activated mast cells and T helper 2 cells release cytokines. And this is going to induce eosinophil maturation. So eosinophils are a type of white blood cell. They're a granulocyte because they have a granular cytoplasm, similar to a neutrophil. Okay, but you can tell the difference under a microscope because they have a different appearance. And when we have our eosinophil maturation, they're going to migrate to different areas. They're going to migrate into the airways. So in particular, the lamina propria, the layer of the bronchioles, into the eyes, particularly the conjunctiva, and also into the nose. So in terms of the airways, this is basically, they essentially release chemicals which cause bronchial constriction. They're going to cause conjunctivitis in the eye. And in terms of the nose, they're going to cause rhinitis. Okay, and we know our eosinophils are associated with that's to do with an allergic response. Okay, an allergic response, and these are all going to contribute to asthma. Okay, so essentially, when we have our delayed attack, okay, and our eosinophilic infiltration of the airways, so it's going to peak about 6 to 8 hours after the trigger, and it should typically resolve within 24 hours. Okay, so I just want to bring you to two diagrams here. So we have this one, and we also have this diagram too. So in this top diagram, we've got a T helper 2 cell. Okay, and this T helper 2 cell, when it's activated, is going to release a substance called a cytokine called interleukin 5, and that's what's going to cause eosinophil activation. Okay, so I just want you to remember that. So interleukin 5 is going to cause eosinophil activation. And then we also have another T helper 2 down here. When it's activated also, it's going to release interleukin 4, and this is going to stimulate the activation and differentiation of plasma cells, which are very, very they're very, very clever cells as they can synthesize proteins, particularly immunoglobulins. So we have our IgE being synthesized, which is also going to contribute to the underlying pathophysiology. Okay. And activation of the T helper 2 cells is basically dependent on another type of cell called an antigen presenting cell. So this could be a macrophage or a dendritic cell. Okay. And on our T helper cell, we have little kind of receptors called CD4, and that means cluster of differentiation 4, and that recognizes another molecule called MHC class 2, so major histocompatibility complex 2, on the antigen presenting cell. And we also have our allergen, what was engulfed by the antigen presenting cell, and that's going to bind to another receptor on the T helper 2 cell called just a T cell receptor, and that's going to result in the release of interleukin 5, and interleukin 4, resulting in eosinophil activation and also plasma cell activation. Okay, so I hope that makes sense. Okay, now let's look at another schematic where we're going to be discussing the clinical features of asthma. So we're going to start up here first. So we know that asthma is variable, sporadic airway obstruction in response to our triggers. If it's severe, there can be reduced alveolar ventilation, and we can have a VQ mismatch. So we're going to have hypoxemia, so low oxygen within the blood. This is going to be detected by the body, and we're going to have an increase in heart rate and also an increase in breathing rate to try and improve tissue perfusion. So this is going to result in tachycardia and tachypnea when you're looking at the observations. Okay, and also during expiration, positive pleural pressures, so the intrapleural pressure, the pressure within the pleural cavity, can squeeze on the airways, leading to obstruction. So this is particularly during forced expiration. Okay, so during forced expiration, say for example, if we look at our triggers, someone's doing exercise and they have to breathe quite heavily when they're breathing out. The intrapleural pressure may become positive relative to the intra-alveolar pressure, relative to the pressure within the alveoli. The pressure within the pleural space is greater than that of the pressure within the alveoli are going to collapse. The airways are going to collapse. Okay, and it's going to contribute to the to the asthma developing, the acute asthma. Okay, so we have gas trapped in the alveoli, leading to lung hyperinflation. This can cause episodic dyspnea, so shortness of breath. The patient must contract their expiratory muscles more forcefully to effectively expire. This can also contribute to shortness of breath. And also, the patient might report chest tightness, an important thing to ask about in the history. So we have narrow airways. Okay, so we're going to have turbulent airflow on auscultation. And when we have asthma, and the patients don't necessarily always have a wheeze, because asthma attacks in particular are paroxysmal, so they might be short, they might only be short and severe, or short and mild. So there's basically a spectrum of the severity. But the fact that they're paroxysmal only means that the short and might sometimes be missed, in terms of when you take a history or when you examine the patient. Okay, but during these attacks, it's reported as a polyphonic, so lots of different sounds, expiratory on expiration, and a wheeze. Okay. During severe attacks, there's going to be use of accessory muscles to increase the thoracic volume. Okay. There's also going to be increased airway obstruction, and the lungs take longer to empty. So because of the increased accessory muscle use, we'll see visible contraction of the scalenes and sternocleidomastoid muscles, which we can see here. We have um, one of our scalenes, so our middle, anterior, and posterior scalenes. And essentially what they do is they elevate the upper ribs to try and increase the volume of the thorax. And we're also going to have contraction of the sternocleidomastoid, which essentially functions to try and elevate the sternum to also increase that intrathoracic volume. Okay. And in terms of the increased airway obstruction and the lungs taking longer to empty, this is going to result in a prolonged expiratory phase of breathing. Okay. So if you observe the patient when they're during the acute asthma, they might have a prolonged expiratory phase of breathing. Okay, so if there's associated eosinophilic infiltration of the nose, the skin, and the eyes, related to the nose, that's going to be rhinitis, to the skin, atopic because it's allergic dermatitis, and the eyes, conjunctivitis. So this can present with a runny nose, a skin rash. You might call it like an urticarial skin rash, and also blurry vision or red eye related to the conjunctivitis. And then this little part at the bottom here about allergic conjunctivitis is for your own reference. Includes some of the clinical features and the management too. So let's talk about asthma in terms of what to ask about in the history, and also what to think about when you're doing a physical examination. And in terms of the history, it's important to get all of the details because of that paroxysmal nature of the condition, because it happens in short little bursts, what you might miss. Okay. And the main symptoms to ask about is like cough, because you can have cough variant asthma where they present primarily with a cough, wheeze, shortness of breath, and chest tightness. Okay, so in the presenting complaint, we want to talk about what happens during an attack, trying to think about if the patient can think of any triggers in particular or what they were doing at the time, um, other key symptoms, respiratory symptoms, and um, and what time of day is basically when the attacks occur. So when is the patient's asthma worse? Okay, and this is known as diurnal variation. And this is diurnal variation just means that the symptoms vary throughout the day and the night, and this might even cause some sleep disturbance too, which isn't particularly pleasant for patients. Also, we need to think about family history. Is there a family history of atopy? Okay, so remember that's asthma, eczema, hay fever. Medication history. Okay, so is the patient on beta blockers, which can cause bronchoconstriction, even if it's topical for things like glaucoma? Are they on aspirin? Are they on other non-steroidals? Okay. Social history, smoking status. Okay, so you want to be very specific when you talk about smoking status. You want to know about, um, you know, how many cigarettes does the patient smoke a day? What are the type of cigarettes that the patient smokes? How long have they been smoking for? Because they could just say to you, I've stopped smoking recently, or I don't smoke. Well, they might have smoked for the last 30 years or something like that. So it's important to really get into the nitty gritty and get into the specifics. Okay, and then ask about occupation when we think about occupational asthma. So exposure to certain dust and chemicals. You can even ask about pets because certain animal danders, so flecks of skin um, from animals, so dogs, cats, um, uh, certain birds people might keep as pets, um, can can be a trigger for asthma. And then you always want to do a cardiorespiratory systems review, and this is different from the history presenting complaint. And you don't want to ask about symptoms which you've already covered in the history presenting complaint. So you can ask about their if they have any sputum. You can explore that even further and ask about the colour if there's any blood. And you can ask about if they've been coughing up any blood, hemoptysis, been having any palpitations, chest pain, and syncope. Because you it's all linked. Your lungs and your heart are all interlinked, so it's important to cover all of the different points. Okay. So let's talk about the respiratory examination related to asthma. Okay. And again, asthma is these episodes are paroxysmal. All right. So the examination may be normal between exacerbations. Okay. I want to mention at this point as well, I'm going to talk more about acute asthma in terms of the severity and what features present in terms of how severe the acute asthma is in another video. Okay. So in terms of our bedside inspection, we're looking for oxygen, inhalers, spacers, and peak expiratory flow devices. In terms of our inspection of the patient, do they have an increased work of breathing, sorry, a cough, an audible wheeze? Can you hear the wheeze without use of your stethoscope? Do they look visibly cyanosed? Okay, you can also check under the tongue for central cyanosis. And they might also be in a tripod position. So they might kind of be leaned quite far forward, sat on the end of the bed. And this is essentially so they can try and ventilate better, try and get that to try and get the air out of the lungs because they have that air trapping because of the airway collapse. Okay, and be a chest expansion when we talk about palpation. And this respiratory examination isn't completely extensive. I haven't included things like assessing for tracheal deviation, but you should be aware of them other aspects of the examination too. Percussion, okay, so we might have increased resonance of the anterior and posterior chest walls because of the air trapping. If we have air with, more air um, within the lungs, this is going to come off as resonant. Patient might, if they have air trapping as well, it might have a barrel chest. Okay, and when we think about auscultation, I've already mentioned this widespread polyphonic expiratory wheeze. So the wheeze is happening on expiration. And in terms of observations, the patient might have tachycardia, there might be tachypneic. Um, in more severe asthma, you can have a phenomenon called pulsus paradoxus happening. Okay, so when the lungs have a larger volume, particularly on inspiration, when the lungs expand and they have a larger volume because of the air trapping, they can compress the pulmonary vasculature. Okay, so we're going to have reduced blood returning to the left atrium, and that's going to basically present as this pulsus paradoxus, a drop in blood pressure greater than 10 millimeters per mercury during inspiration. Okay, but that tends to be if the attack's more severe. Okay. Okay, and we've mentioned about percussion, remembering to assess the back of the patient as well as the front of the chest. Very important for cardiorespiratory examinations. Okay, if the patient is if they have chronic asthma, so they've had asthma for a long time, you might be able to hear these sounds called rhonchi. So they're almost like low-pitched snoring sounds, and they can be temporarily relieved by coughing. So that they might be scattered across the chest. Okay. And rhonchi are the opposite to rails, because rails are more kind of um, high pitched sounds, and typically at the lung bases. Okay. Other things to consider is examination, particularly if we're talking about allergic asthma. Well, you want to do it anyway, but you want to examine the eyes, signs of conjunctivitis, the nose, particularly in aspirin sensitivity, thinking about nasal polyps, and also inspection of the skin for urticarial rash. Okay, so you might remember from earlier in the video, we had this lovely, nice, normal-looking bronchial, okay, with our nice blood vessels within the lamina propria, our thin layer of mucus, and also our ciliated epithelium. Okay? Remembering our smooth muscle layer too. But when we have the chronic process of asthma happening, we can have physical alterations to the bronchioles, and they're going to look more like this. And you know, in my opinion, this one on the left-hand side looks much nicer. So let's go into a bit more detail about what's been going on here. So we can see from the diagram that the epithelium is inflamed. It's inflamed, and the damaged epithelium releases inflammatory mediators, cytokines, and different growth factors which promote tissue remodeling. There's also increased production of nitric oxide due to activation of nitric oxide synthase. So the activation of that enzyme is a sign of inflammation. And when we have um, nitric oxide production in an excessive amount, it's going to cause smooth muscle spasm and hence bronchoconstriction. Okay, because nitric oxide normally relaxes bronchial smooth muscle. Okay, but it has this opposite effect in our inflammatory state. Okay, we can also see that our surface mucus is a lot thicker, and that's because we have goblet cell um, proliferation and increased activity, hence the reason why we have more mucus here. And our lumen, our center, so if you look on the diagram on the left, our lumen's nice and wide, okay, so that's going to allow the lungs to ventilate, air to come in and air to come out. But if you look here, our lumen's very narrow, so that's not great. Okay. And within our lamina propria, we can see that we have quite a lot going on now. So we have some dilated blood vessels. Our blood vessels are dilated. There's increased vascular permeability. Remember, that's caused by histamine and specific leukotrienes. Okay. And we can also see that we have some these green dots here are cells. So these are going to be our T helper 2 cells and also our eosinophils if we're thinking about allergic asthma, so atopic asthma. Okay, so they've infiltrated the lamina propria of the bronchioles. Okay, which I've just this is just the label for that. we're going to have increased fibrosis. So we can see these brown structures here. This is meant to illustrate the increased fibrosis of the basement membrane. Okay, and essentially why we have this, we have a thickened basement membrane due to deposition of repair collagens and matrix proteins, such as laminin and fibronectin. Okay, and these are deposited due to the conversion of fibroblasts into which essentially change into another type of cell called contractile myofibroblasts. Okay, and we also have a hyperplastic smooth muscle. So we can see the smooth muscle layer on this diagram on the right is much thicker than the one on the left. Okay, and this is because the smooth muscle it proliferates in response to these growth factors and inflammatory cytokines, and then it ends up producing inflammatory cytokines and growth factors itself. So it's kind of feed into the process. So it's in this hyperplastic state. There's more cells, and there's a reduced. It doesn't have to be stimulated as much to be in a contracted state. So when we think about chronic asthma, we have the smooth muscle that's going to be in this contracted state. Okay, it's going to be in this contracted state. And then when we think about nerves, basically parasympathetic nerves can stimulate receptors on the bronchial smooth muscle called muscarinic M3 receptors, and this can further contribute to bronchoconstriction. Okay, so that's everything for today. Thank you so much for watching, and stay tuned for part 2, where we're going to focus on asthma investigations, management, and complications. Okay, and then in another video, we're going to talk about acute asthma in more detail and how that can be managed. So if you found this video useful, make sure to give it a like and leave a comment, and also subscribe if you're new to the channel. So with that being said, thank you very much for watching. I really appreciate all the support I've gotten so far, and take care, and I'll see you in the next video.